Sinusitis. Sinusitis is a common infection that may occur in any of the paranasal sinuses. Sinusitiis is infection of more than one sinus. The term rhinosinusitis is thought to more accurately describe respiratory manifestations referable to an inflammatory disease of the nose or sinuses. Sinusitis is a common medical condition that affects an estimated 35 million people a year. Pathophysiology. The sinuses are protected against infection by mucociliary action. The normal mucus produced by the sinuses is removed through small openings in the nose called ostia. When the ciliary action is impaired or the ostia are obstructed, mucus can accumulate in the sinus, which may then become infected. Etiology. Blockage of the ostia may be due to a deviated nasal septum, bony abnormalities, congenital malformations, infections, or allergy. Diagnostic tests. A medical diagnosis of sinusitis is suggested by the client's clinical manifestations, confirmed by X-ray findings and CT scan. Signs and symptoms. Fever and chills along with headaches. Facial pain exacerbated with bending greater than pain or numbness in the upper teeth. A purulent or discolored nasal discharge may be present. Sinus radiographs or CT scans may show opacification of the sinus, thickened mucous membranes, and an air fluid level attributable to accumulation of secretions in the sinus, all indicative of sinusitis. Medical management. Medical management of sinusitis includes 1. Use of the appropriate antibiotic to manage the bacterial infection. 2. Decongestants to reduce nasal edema. 3. Corticosteroid nasal sprays to reduce mucosal inflammation, and 4. Humidification by use of normal saline solution irrigations or a vaporizer or humidifier to prevent nasal crusting and to moisten secretions. 5. Antibiotics are not prescribed routinely, because many cases of sinusitis are viral. Initial selection of antibiotics is based on the likely causative organisms indicated by the manifestations and the probability of resistant strains within a community. First line therapy at most centers is amoxicillin for 14 days. Medical means of providing drainage include topical and systemic vasoconstrictors. 6. Oral alpha-adrenergic oral vasoconstrictors, including pseudoephedrine and phenylephrine, can be used for 10 to 14 days, allowing for restoration of normal mucociliary function and drainage. They may be contraindicated in clients with cardiovascular disease because they may cause hypertension and tachycardia. 7. They also may be contraindicated in competitive athletes because of rules of competition. 8. Mucolytic agents such as guaifenesin and saline lavage have been shown to decrease the duration of sinus infections and can be performed by the client at home. 9. Intranasal steroids are also commonly prescribed. 10. Antihistamines are beneficial for reducing osteometal obstruction in clients with allergies and acute sinusitis. 11. Antral irrigation or sinus lavage may be performed in clients who are not responding to treatment or who have increased purulent exudate in the maxillary sinus. Antral irrigation is performed with the use of a local anesthetic. A trocar, a sharp metal instrument, is inserted through the ostium in the lateral wall of the nose into the sinus. Prepare the client for the procedure with thorough explanations of the anesthetic procedure, the sensation of passage of the trocar through the ostium, and feelings of pressure. Normal saline solution is then injected through the cannula to rinse the sinus of purulent exudate. The client is placed in a sitting position, leaning slightly forward with the mouth open to allow drainage of the irrigating solution through the nose and mouth. A specimen of the exudate may be obtained for culture to determine the causative organism for prescription of an appropriate antibiotic. Surgical management. 1. Functional endoscopic sinus surgery. If non-operative measures fail, functional endoscopic sinus surgery, FESS, may be necessary. The major objective of FESS is the re-establishment of sinus ventilation and mucociliary clearance. FESS is usually performed as an outpatient surgical procedure using local anesthesia, with or without conscious sedation, or with the client under general anesthesia. Small fiber optic endoscopes are passed through the nasal cavity and into the sinuses to allow direct visualization of the sinuses in order to remove diseased tissue and to enlarge ostia. Possible complications of FESS include nasal bleeding, pain, scar formation and, rarely, cerebrospinal fluid leak and blindness resulting from intraorbital hematoma formation or direct injury to the optic nerve. After FESS, nasal packing may be inserted to minimize nasal bleeding. Packing is removed within a few hours of the surgical procedure. 2. External sphenoethmoidectomy. External sphenoethmoidectomy is a surgical performed to remove diseased mucosa from the sphenoidal or ethmoidal sinus. A small incision is the ethmoidal sinus on the lateral nasal bod. Diseased mucosa is removed. Nasal and ething is then inserted. An eye pressure pack applied to decrease periorbital edema. Nursing management. 1. For the first 24 hours after sinus surgery, observe for profuse nasal bleeding, respiratory ecchymosis, and orbital and facial edema. 2. Apply compresses to the nose and cheek to minimize and control bleeding. 3. Place the client in a position with the head of the bed greater than 45 degrees for 48 hours after surgery to minimize postoperative edema. 4. The nasal packing is generally removed after surgery, however, antral packing may place for 36 to 72 hours. 5. Give mild analgesics. 6. Instruct clients to increase fluid intake, which maximizes the water content of secretions. 7. Minor nasal bleeding is expected for 24 to 48 hours after surgery. 8. Use of a drip pad under the nose may eliminate the need for constant wiping. 9. Instruct clients to avoid blowing the nose for 7 to 10 days after surgery. Tell them to sniff backward or spit, not blow. 10. Teach the client to sneeze only with the mouth open. 11. Nasal saline sprays may be started 3 to 5 days after surgery to moisten the nasal mucosa. 12. Explain that the client is to engage in minimal physical exercise and to avoid strenuous activity, lifting, and straining for approximately 2 weeks. 13. After FESS, the client needs to return to the physician's office for removal of crusts and debris and for examination of the nose.